7:03. Let us get started. Good evening all to the 61st session of the Weekly Huddle. I'm your host Anoop, and joining me today is my friend and co-host Praneeth. We are a couple of cardiologists working at Care Hospital, Banjara Hills, and we have been doing this weekly session for the past 61 weeks. So this is our 61st episode. As most of you know, the huddle is an unscripted audience level interaction where we address common clinical scenarios that we encounter in our daily practice. We typically pick up a topic or a clinical case like what we are doing today, and we restrict our discussion around that. The basic premise of the huddle is to bring our casual hallway discussions to a more organized platform like this one and share our ideas. While we do welcome signs and guidelines, with the huddle, we intend to help a physician translate established knowledge to clinical practice, taking local factors and practice patterns into account. This is not a speaker and an audience model, rather a casual interaction, which means that any one of the attendees, they can raise their hand or unmute themselves if they have anything to say or give their input. As a courtesy, you should wait for others to finish their thoughts before you unmute yourself. So having said that, let me start today's clinical case. And then I will, as a customary, I always ask my co-host Praneeth for his initial impression. And then we go down our attendees, the list of our attendees, and ask their input. So with this, let me get started. And before I do so, my heartfelt thanks to Dr. Vishwakranth. Dr. Vishwakranth is one of our cardiologists. He practices out of Care Hospital, Mushirabad primarily. And he's senior to me. And the case that we are discussing today is actually Dr. Vishwakranth. So, sir, thank you so much for doing this. It takes a lot of effort and courage to talk about one's own health issues and discuss it on a public forum. So I really appreciate you accepting my invitation. And let's see if we can make it a little bit fun and a little bit knowledgeable at the same time. So having said that, since we have Dr. Vishwakranth with us, any of the attendees, if they have any particular question about this case, please feel free to directly address it to Dr. Vishwakranth. He will be able to answer it, playing a double role here as a patient as well as an established cardiologist. I'm sure Dr. Vishwakranth will be able to share his perspective to you on both the fronts. So having said that, let me brief out the case to you, and then we will go to Praneeth for his impression, and then we will discuss with others. So the case that we are discussing today is of a 41-year-old male. I'm sorry, Dr. Vishwakranth, I'm disclosing your age. He's a cardiologist by profession and very good one at that. He had been having rapidly progressive fever for 36 hours, which in patient's opinion, it was like he was feeling fine and then it almost hit him suddenly. And the fever was accompanied with cough, malaise, and loss of taste. Patient, as is the current scenario, he isolated himself and got himself tested for COVID, which came back positive. So he has a positive report, I believe, by day 3 of his symptom onset. His oxygen saturation is above 94 and rest of the vitals are reasonably maintained. No routine labs were done at this time. Because he is a healthcare provider, he got the COVID vaccination in the very first phase of vaccination drive that was happening in India. And he got his second dose of Covishield completed by March 28th. So that is almost like more than 2.5 months that he had been vaccinated. He does not have any comorbidities. So here we have a young individual with no comorbidities, COVID symptom, COVID positivity, without any red flag signs. He's on day 3 right now. And the discussion point that we have for this particular case is, should he go for the antibody-drug cocktail, which is currently available in India for the past, I would say maybe 3 weeks or so? and whether he can go for antibody cocktail or not, having the fact that he had already been vaccinated. So how does the vaccination status get his eligibility for this antibody drug cocktail? And then the subsequent discussion point would be, what would be general precautions related to this therapy in case if we offer this therapy to our patients? What would be the general precautions that we would ask our patients to follow? And now, since we know about COVID for more than a year or so, what are the more contemporary ancillary treatment and investigations that we do in the current COVID era? I remember we started from hydroxychloroquine to azithromycin to ivermectin to God knows what all. And of course, remdesivir came in there, dexamethasone came in there, tocilizumab came in there, and there were probably 20 others. And not to forget, Coronil and everything else came in there. So in the current era where we know a little bit about how COVID behaves, what should be the contemporary ancillary treatment and investigation considering this index patient that we're talking about? So Praneeth, on to you. You have a case here, you have a patient in the audience. How would you go about it? Please share your thoughts and then we'll go down the list that we have today.
Yeah, good evening, everyone. Firstly, special thanks to Vishwakranth sir for accommodating. Anoop, this case, I'm here more to learn. All those questions are equally there in my mind, so I don't think I can add much to it. I have more to learn here than to add here. So I think without wasting much of time, take the opinions of the concerned specialist, and I'm here to learn today. Not much to contribute from my side.
Okay, Praneeth, let us then talk to experts that we have. But before I do so, Vishwakranth sir, do you want to add anything in terms of your clinical presentation that I missed? Did I cover most of relevant points or something you want to discuss beforehand?
Dr. Anoop, am I audible?
Yes, sir, you are audible.
Thank you very much, Anoop, for the invitation. I am enjoying as much as you are being in this part of this huddle. You guys are doing a great job. And this case, I mean, in this issue, I mean, I'm glad to have been both as a doctor and also a patient. It's quite rare anyone gets that opportunity, I guess. But like I said, COVID is making us think a lot differently, and it has made me think differently as well. As far as my clinical presentation is concerned, I think by day 3, my COVID report, I had sent my RT-PCR, it was positive. I had classical symptoms like 101 degrees Fahrenheit fever, sore throat, cough, dry cough, and nasal stuffiness. I mean, these were very, and of course, at that time, I did not have much loss of smell and space. I still don't have, and those other symptoms were not there. I had cough pains to add to that. The time when the fever started, I realized that something is not right. This is not an usual thing. I isolated myself, and then on day 3, I got the RT-PCR done. RT-PCR report was there positive with a cycle count of 17, which was, fairly high viral load. And lab work, which I sent at that time, were all normal, including CRP, LDH, or whatnot anyone might ask, I would say. CBP showed a viral picture. Other than that, there was nothing in that. And I consulted a few doctors at every critical care specialist in all 3 centers, you might say, from Nampalli, Mushirabad, and Banjara. Everyone suggested it's available, you go for it. And then on day,
sir,
let us,
what all blood tests you got? IL-6, CRP, and what else? The special test.
LDH, ferritin, you name it, whatever is being sent every time for the COVID profile. And the thing is, I sent my antibodies at the same time.
We'll talk about your antibody. Vishwakranth sir, we will talk about your antibodies in a second. Okay. And D-dimer also you sent?
Yes. Everything.
They were all normal, I'm guessing.
Normal. There was no indication to say in the blood reports that things were going in a downward fashion.
Perfect.
Then there was a suggestion was given. I mean, I took the suggestion and I went ahead the next day with this antibodies. It consists of a light cocktail with two drugs, half of it 600 mg twice, which we will go further. And I took it in the afternoon. By evening, my cough subsided. By next day morning, I had no fever. And I became totally asymptomatic 48 hours later. Totally.
Perfect. Thank you.
Nothing, everything by 48 hours later. And RT-PCR report I had sent this maybe I would say day 10 negative.
Perfect.
Negative. I repeated it also. But if there is any queries, if anyone want to ask, so I would say as a patient, I'm a 41-year-old healthcare professional who was 3 days into COVID, taken the lytic antibody therapy and became asymptomatic in 48 hours and RT-PCR negative by day 10, if I may put forward in that fashion.
Perfect. Thank you so much, sir. And we certainly will have more questions. So let me first get my attendees for their opinion. And then I'm sure we will have more questions or suggestions to ask from you. We have Guru Prasad sir here. Guru Prasad sir is an internal medicine consultant at Care Banjara. Sir, you heard the case. Walk us through what is your thought process. How would you take it?
Yeah, good evening to all of you, and thank you, Anoop and Praneeth, to have invited me. So, monoclonal antibody has been a subject of debate in whether to use or not to use in patients who are having COVID, because the rationale of use is basically to decrease the viremia, and the earlier the use, the better it is. So here the case in point actually is the classic where we have early diagnosis of COVID, and we had the opportunity to use monoclonal antibody. It would have been fairly simple if this patient was not vaccinated and he had not received both the vaccines, dose of vaccines, and then it makes sense to probably give monoclonal antibody and clear off the virus so that the chance of him going into the inflammatory stage actually comes down dramatically because you have decreased the viral load. But here, because the patient was vaccinated and apparently he had antibodies, he had or didn't have antibodies is what we need to know actually. So the study which was done in NEJM with monoclonal antibodies, especially the Trump cocktail, which is now being used, or I may use the general name which are being used, is that they studied patients who got the vaccine but they didn't have antibodies. So in them, that was one inclusion criteria to use this monoclonal antibody. But again, I will reiterate that even though a minority of patients only need hospital admission and a lesser number of people actually require ICU admission, for the people who become sick or who go into ICU, it is like the statistics don't matter anymore. It is 100% for them. So for those 5% of patients, if we could have prevented those 5% from going into the hyperimmune stage and reduce the viral load initially, they would not go into this complication of inflammatory stage. So now the toss-up is between that, because the majority of the patients actually would recover without this therapy. Are we really warranted in giving this therapy initially, because those patients might actually become normal anyway? That's why some guidelines have been formulated where patients with CKD or patients whose BMI is more, or people who have uncontrolled type 2 diabetes mellitus, or have some other respiratory problems like COPD, they are the people who are to be included into definitely using monoclonal antibody. That is one risk factor for developing a severe disease. But if a patient asks me that, yeah, we have this therapy, do we really go ahead with this therapy? I would say, why not? Because what we are giving, a therapy may or may not be efficacious, which should not cause any harm. So the primary therapy, when we use any therapy, is that it should cause no harm. And if that endpoint is being fulfilled, and you can give a therapy to kind of probably ameliorate the patient's symptoms and prevent him from going into an inflammatory cascade. So from the standpoint of the initial phase of the illness, third, fourth day, it is difficult to say which patient will go into the inflammatory phase. So fundamentally in any viral infection is that you reduce the viremia and then you prevent the inflammatory phase from occurring. So I would actually, I think, commend the critical care doctors of Nampally, Mishirabad, and Banjara to have actually advised Dr. Vishwakranth to go ahead and take the monoclonal antibody. But mind it that once you take the monoclonal antibody, if you're not vaccinated, you cannot take the vaccine for next 3 months.
And sir, what is that antibody thing you were saying? If the patient has antibody present after vaccination, then they should not go for monoclonal antibody. Is that correct?
No, it's not that way. Actually, the study in NEJM, they wanted to exclude out patients who had antibodies post-vaccination as a part of the study group, because they were actually studying the efficacy of this casirivimab and imidavab combination. But there is no hard and fast exclusion in the product monograph of the cocktail antibody. So it's like an immune boost. So for example, there's been a lot of talk about heterogeneous vaccines where we are using 2 doses of Covishield and the third dose. Now there's a study which has come out that you use mRNA vaccine. So you're boosting the immunity by using another vaccine now. Same thing happens when you use a monoclonal antibody. Basically, you're boosting the patient's immune, the antibodies to fight against the virus. So it doesn't really harm the patient in any way to use the antibody, apart from setting you back by around 60,000 rupees.
And after vaccination, having antibody in your blood versus not having antibody in your blood, is that kind of a discrete way of saying you are protected versus you are not protected? Is there some thought process around it?
So the studies which have been published by ICMR have actually enumerated if you have taken the vaccine, how many patients are protected against the disease, against the infection, against moderate disease, and against severe disease. So severe disease were around 93% to be precise, if I'm not mistaken, with Covishield and Covaxin. Infection was around 60%. So even if you are taken Covaxin, you may still get infected with the virus in 40% of the times, because there is a lot of talk about the antibodies which are there. We are actually looking at antibody titers. But again, in the antibodies, the COVID is such a complicated disease that in even antibodies, there are subset of antibodies which are protective against COVID, and antibodies which may just be innocent bystanders. They may actually not be effective against COVID. So having a very high titer doesn't really say that you are, kind of you are safe and you cannot get the disease. Yes, it may mean that if you get the disease, you may get a milder form of disease, and you may not land up in the hospital with a SARS kind of illness. But having antibody and having no antibody, I would say that people who have an antibody are probably protected against a disease, against a severe disease, versus people not having the antibody at all. There have been people who have taken both the doses of vaccines, and once they got their antibody tested, there were no antibodies at all. But there are a lot of immunologists who have been talking about it, and they're saying that actually what matters is the T cell memory. The moment you are exposed to a vaccine and your body identifies it, you may not have mounted an immune response immediately to it, but when the actual time comes, there's something called T cell memory which might just kick in at that point of time and protect you. So that is all speculation at this point of time.
Perfect. Thank you so much, sir. We have Dr. Deepak with us. Dr. Deepak, I believe, is a critical care expert. Sir, please correct me if I'm wrong. You heard the case. If you could give your thought process, and also there is a question in the chat box that what is the fundamental difference between plasma therapy and antibody cocktail? Deepak, please.
Yeah, thank you, Dr. Anoop. Let me first say that I'm happy that Dr. Vishwakranth has recorded very well, and it's good to hear from seniors like Dr. Guruprasad sir. So for me, I usually depends basically on where the stage of the disease is, and it depends on whether the phase of viremia or whether the phase of inflammation has set in. So whatever the antivirals are, like last time we discussed some agents, this time monoclonal antibodies, whichever it is, we are talking about the stage of viremia. So our practice has been at Apollo, once the symptom onset has started, and once the positive result has come, the role is as early as possible you will give the antibodies. The more the delay is, the lesser the benefit it is. And for us, the practice is we'll get an antibody test done for the patient, neutralizing antibodies.
once that is when we tell the patients that if the antibodies are positive, the chance of the expensive therapy being efficacious is less and less. Whereas if the antibodies are negative and they fall into the stage of early disease, not requiring oxygen especially, and if they have a significant risk factors, the benefit may be more. And we also tell that the risk of progression is less, but we cannot be very sure about it. And the difficulty here being the lack of like equivalence between measuring the antibodies. So if you see various labs in the city, they give various results. And I've seen people with very high antibody titers in done some labs getting tested in some other labs having absolutely no antibodies. As told by the previous speaker, all the theory revolves behind that the presence of antibody itself means that the patient has some amount of protection, but it still is a big theory. And all these studies, the study done in the NEJM and the subsequent study published, which was comparing interferons versus the monoclonal antibody, they have measured the viral copies, which in actually in real life we are not measuring the viral load of the patient. So for us, like our experience has been limited. We have been using maybe around I think 1 month, or I think at the max 1.5 months. Uh, for us, one or two, three things which I found is there has been abuse of the antibodies as well. We strictly try to reduce it because later the part of it, and the criteria being you need to have strict criteria. The hospitalized patients and the oxygen dependent patients, you should not give it. In fact, it was showed that if you give to those set of patients, the outcomes will be actually worse than like the patients who didn't receive it. So, and one or two, three things is bradycardia is one thing which we observed, and some patients the fever tends to flare up, which I subsequently subside after 2 or 3 days. But these two things we observed in our set of patients. And the present new thinking is the high dose like casirivimab plus imdevimab. There are 2 or 3 studies which came, and the patient is much more sicker. Now they are going for higher doses, so which really doesn't have strong evidence, but I think the evidence is mounting. So maybe we'll see it in the later part of the time. Thank you.
Perfect. Thank you so much, sir. Let me see who all is there, and then we will.
Anoop, there was some query about the plasma versus monoclonal antibody.
Yes.
So, if you permit me, can I answer that?
Please, sir. Please. Guru sir, go ahead.
So plasma therapy actually is basically has polyclonal antibodies. So there is no. So for example, if we go back around 100 years back, there was a study done by Dr. Finland who used actually horse antisera for he inoculated the horses with pneumococcal bacteria, and then depending on what subtype of pneumococcus the patient had, he used to take out that particular antisera and give to that patient. So that was the initial phases of vaccination. So this is the same principle we're using when you're using monoclonal antibody. Monoclonal antibody is highly specific, like it is. But the current antibody which we're using is from one patient from USA, and the other part is from a patient from Wuhan, China. So basically, they clone that antibody and they make it monoclonal. So plasma therapy is polyclonal antibodies, and monoclonal antibodies, as the name suggests, is monoclonal. So it is like it is against the spike protein of the virus. So theoretically, it is much more efficacious. And studies-wise, also the primary endpoints, as Dr. Deepak was mentioning, is that viral load and all these things were secondary endpoints in the study. The primary endpoints was time to discharge and requirement for oxygenation or ventilator, and third was death. These three primary endpoints actually, if they compare to placebo, monoclonal antibodies fared much better. Thank you.
So do you know if antibodies are derived from human or concentrated form of human plasma, or they're actually cloned in the lab, or they're cloned in the lab?
No. They are concentrated from the human plasma only. That's what I was saying. The current antibody which is now in trial, I've forgotten the name. The two subtypes of the antibodies. One is from a patient from the USA. Second is from a patient from Wuhan, China. So they, they purify it further and make it monoclonal. So that's what is given to the patients actually. And again, they're cloned in the lab. So subsequently, they're cloned in the lab, the antibodies.
So the mass production happens in the lab, I'm guessing, right? That is what you're saying.
Yes, exactly. So the origin is from a patient only.
Right. The footprint comes from the patient, but then the mass production happens in the lab.
Yeah. Yes.
So there is no risk for antigen reaction in the human body, I'm guessing. There is no like antigen particles from some other person.
Theoretically, there is because as they were saying that any immunoglobulin when we give, there's always a chance of something like a serum sickness happening, but that is more with the animal, like the horse antisera. Human antibodies also are known to cause serum sickness. In fact, fevers might increase again after you give antibodies, and some people develop myocarditis and other inflammation, something like an MIS, because of the hyperimmune globulin which we are giving. But that is not been shown, at least demonstrated in studies till now with the monoclonal antibody against COVID-19.
Perfect. Thank you so much, sir. Vishwakranth sir, if I can have you turn off your mic one more time. So we discussed about the antibody level, that if the antibody level is low, then it makes more sense to go for antibody drug cocktail. If you could just share your information. And you also briefly mentioned that after taking the cocktail, you felt better. Could you just walk us through the steps in terms of what it is to take the antibody cocktail, how long it takes, how is it administered, the price associated, and did you experience any side effects with that drug?
Yeah, no, really, when I was asked to take the antibodies, I did research myself. I mean, regarding this antibodies in COVID and all. And research, I mean, not going through the net and all. I specifically found out about a patient experience who have taken it. It is difficult to trace them as a doctor itself, but then I have personally asked few of the doctor colleagues who have really given them, and I've really found out how the patients were feeling, because some of them were like, so I had some relatives to me too. Exactly. Everyone says 90% of the time they say this, that they are absolutely fine by 48 hours. And in fact, some aggressively went ahead and did COVID RT-PCR after 3 or 4 days too. I didn't do that, but they were negative after 3 or 4 days. Patient experiences, which was one which had made me go through it, and that is number one. And regarding the therapy, I mean, the therapy was, it was just 2 injections. They diluted in about 200 ml and fairness and give it slowly initially, IV. There is a notion to give it subcutaneous too, but then we didn't go through all that issues. Then slowly, precaution should be taken that it is fully diluted, and there should not be any precipitate when you are diluting it, because the more the precipitate, the more chances you will have an anaphylaxis. Anaphylaxis is something you can have because it is after all a protein and you might have it. And I had no reactions as of during the administration, and it was over by in a half an hour to 45 minutes. I stood there, I was observed probably for half an hour more, and I had my lunch and I walked out. And then towards the evening, 4 hours, I had own fever, close to 102 or even higher. That took some time to come down. I mean, I had to use, they had asked me to keep the IV cannula for 24 hours, just in case. I had kept it, that the rebound fever was there, and it subsided with a couple of tablets of Dolo and some tepid sponging. After that, there was no issue at all. I mean, I was all right after 48 hours. My personal interest in this monoclonal antibodies in COVID began when I personally treated a couple of patients who were really sick. The other antibody, monoclonal antibody, which of course it is not under discussion because which is given slightly later, which I gave maybe 15 days before myself, which really got me going into this monoclonal therapies in COVID, was bevacizumab, which was like a small elder brother of tocilizumab. I really gave that to one of my patients who were really close to me and who was really at 10 days, at day 10, who was having a high flow oxygen and he was just going into an NIV. He became all right after 48 hours. I personally feel, with whatever research I have done, with whatever all these papers and also patient experiences and what it is given, monoclonal therapy, monoclonal antibodies is the therapy which will make us beat this COVID pandemic. Yes, presently the cost is, the vial costs 1200 mg vials are available and you will be given only 600 mg, 2 vials. So you will be paid full. And if someone else takes, a opened vial is kept for about 72 hours. If someone else takes, they will repay you back another half of it. The total amount charged was about 1.2 and you will be repaid back. That's about the monetary aspects of it.
And sir, what was your antibody level when you checked before the
Yes,
drug?
I even before I thought it would be positive, I knew it would be positive if there is a chance I should take it. So I gave my antibodies. IgG levels were around 0.8. But I don't think so there is any correlation with the antibodies with the clinical symptom and whether they will protect you in the long run. That's the main problem of measuring this. Yes, of course, people suggested to measure spike protein specific antibodies, which is done by Tenet and which we are doing it by the help of Tenet. And those are really, I think, more than 150, a rough estimate I am giving you. I don't think that I can back any data to back my whatever I'm saying. But then this is like you said, an informal thing. Just if I suggest someone, I would see if it is that spike protein antibody are more than 150, then I would really not really push, especially a guy who is vaccinated. I think he would have been all right. Just for an example to this, the person from whom I got it was also a doctor, and his spike protein antibodies was 170, 170. And he still took it because he was in a high risk zone, about 67 years and diabetic and all. But he still took it and he became all right after 48 hours. So the antibodies are really protecting and will really stop you not going into your high risk subset. That's a big question mark presently in our present research, in our present knowledge of COVID. The risk we estimate, as a cardiologist, we do risk estimation day in and day out, but we have the habit of doing it over a period of time. But the point of risk estimation when it comes to COVID is you can estimate it only at a point of time. You don't know what's going to happen next 48, once 7 days crosses, and you lose this window of not giving this antibody, which is best when it given between 5 to 7 days window. And then you are already into this immune phase where you have lost this horse has already bolted. That's the main issue with this COVID and antibodies.
Sir, did you get your spike protein specific antibody tested? Is that what it is called? Spike protein specific antibody?
Yes, it's called spike protein specific antibody. I did not get tested that because I only knew that it would be called that only after getting the routine IgG. My IgG was around 0.87. Of course, to say that it was higher than my wife's was only 0.5 and she was negative and she never had any symptoms.
And I'm guessing that anything less than 6 is considered negative. Is that correct?
As per the report given, less than 1 is considered negative.
Less than 1 is considered negative. Okay. Okay. All right.
Report given by the lab there. It was considered IgG less than 1 is basically non-protective and considered to be negative as per their report.
Perfect. So anything more than 1 will be considered positive, and I'm sure all of us have seen patient reports where their IgG levels are more than 200, more than 250. So whether that really means that they are super protected from the virus or not, I don't know. Maybe if somebody has an idea, they can share their thought. But does anyone know why the vials are coming in 1200 milligrams and not 600 milligrams? Why is this whole idea of 2 doses in one vial? Because it unnecessarily increases the cost, and we really can't be that lucky to have 2 patients going in at the same time to get the antibody dosing. Does anybody has any clue why there are 2 doses in one vial?
If I may answer, Anoop, regarding
Yes.
that, what I have
Yes, sir.
searched and what I have learned. See, the data is they have tested it with 1200, 2400, and 600, and placebo.
Hmm.
As
Okay.
per their initial, that whatever article and their recommendation, and I think what Donald Trump got was 1200.
Okay.
When they interpolated those results, and with this and our Caucasian and our subsets with low body mass and all that, I think they made this correction of only 600 is enough. That's what I get to know. I can't say the source. It was all unofficial talk, which I can say.
We have Dr. Karthik Visal with us. Dr. Karthik is a critical care specialist at Yashoda. Karthik sir, you heard the entire clinical discussion and the story. Your thoughts, whatever we have been discussing so far?
Yeah, so thank you, Anoop, for and Dr. Praneeth for having me here. And I've been patiently listening to the whole discussion, and it was really an interesting discussion that we had. And I'm glad Dr. Vempati Vishwakranth sir also made a happy ending and a fast recovery. I would like to make two observations regarding the subsect in where you have to use monoclonal antibodies. It has already been talked about to stop over usage of these antibodies. It's mostly indicated in those group of patients who are considered high risk. And since most of you cardiologists are there, hypertension patients having hypertension is also one of the what do I say risk factor for having a progressive or a severe COVID disease. And apart from hypertension, there are many other factors like obesity and patients who are having immunosuppressed state, and like the list goes on. So most of the patients who come with an early COVID disease and mostly have one of these risk factors, and rightfully giving them monoclonal antibodies the earliest would help. But I would like to make another observation regarding these antibody observations in whether you are considering monoclonal or whether you are seeing for the efficacy of vaccination. It also depends on the type of vaccine that you are taking. We have vaccines which are on two different platforms. We have vaccines which are basically give immunity through T cell mediated immunity, and vaccines which are giving you immunity through a B cell mediated immunity more. Like you have Covishield, it has an adenovirus which infects the cell, and once it cell is infected, then your T cell immunity kicks in, and that is the predominant immunity that you'll have with this vaccine. But if you consider vaccines that are given in the West, like this Moderna or the Pfizer dose vaccine, they are basically B cell antibody mediated responses. So if you have to compare for all these vaccines with a single test like IgG, it wouldn't be a right approach. Like Dr. Guru Prasad also was telling that there are three different types of antibodies that are generated. One is the trimeric anti-spike protein, the domain receptor binding protein, and neutralizing antibodies. Neutralizing antibodies are mostly done in laboratory conditions, but we have the spike protein that is being done quite often. And the T cell immunity response, we don't judge it because we don't have the tests for lab level to interpret these data. So just seeing the antibody IgG levels, it's not fair to judge the response of the vaccine. And but at all, how we practice is we do look at the inflammatory mediators before we administer to the monoclonal antibodies. So that is one way. Probably that was not seen in the earlier studies that were forming the basis for the usage of monoclonal antibodies. But if we have inflammatory mediators which are high, say like the D-dimer ferritin, then probably that patient wouldn't be a ideal patient for taking monoclonal antibody. If you have the inflammatory mediators which are on the lower side or near normal seronegative patients or having age of more than 65 years and with one of those risk factors, they would be an ideal patients to whom we can give these monoclonal antibodies. These are few of my observations, and most of them have been already discussed at length, so I don't have any more to add to them.
So Karthik sir, if I heard you correctly, you said if the inflammatory markers are high, then they are not a good candidate for antibody therapy. Did I hear you correct?
That is a kind of practice that few of us are following, but it's not scientifically backed. The scientific literature definitely tells you about the oxygen requirement. That is one of the parameters that you take up. If you have a oxygen saturation of more than 93 would be ideal candidate. Age would be another factor. And the third one would be the comorbidities and the earliest that you give. In the studies they have given within 3 days. Some studies have given within 7 days of having a positive report. So these are the literature backed data. What I am talking to you about is personal based observation and how we go about it.
So that we understand. So the rationale of not giving therapy, or I would say that making a patient less attractive of an candidate when inflammatory markers are high, is it because the rationale is that the inflammation has already set in, so there is no point giving antibodies? Is that the thought process? Is the thought process that we have to make?
Exactly. Probably they wouldn't be categorized as a mild COVID disease where the antibody cocktail has a major role. Probably these patients are already set into an inflammatory cascade. So these patients wouldn't have much benefit by taking the cocktail regimen. That is what the thought process is.
I see. I see.
If you
Perfect.
allow me, I'm like, can I?
Yes, sir.
Yeah.
Yes, please.
One thing about the same thing. So when you're interpreting an inflammatory marker, you need to understand the stage of the disease. For example, somebody does a CRP on the second day and its CRP is around 50 or 60. I would understand that is because of the infection and the viremia part, and he is a candidate who likely responds to this kind of therapies. Whereas you do the same CRP on maybe a 10th day or 11th day, it indicates that he is in an inflammatory phase. So that basically indicates that he is in advanced stage, maybe a moderate disease or more than that. So the most important thing is to understand the chronology of the symptom after the symptom onset. Thank you.
Perfect. Thank you. One question that has been asked is there any contraindication to monoclonal antibody other than obviously a previous anaphylactic reaction? Karthik sir or Deepak sir, anybody? Is there any contraindication?
Obvious anaphylaxis or hypersensitivity, as everyone knows, and the groups which were not investigated were the pediatric age groups and the weight less than 40 kgs. But I don't think any other obvious contraindications which I'm aware of.
No. I'm not aware of any such contraindications to monoclonal antibody.
Perfect. Thank you so much, sir. Guru sir, I'm going to come back to you for one last direct question of mine, and then we will see if attendees have any questions. Sir, the last point of discussion that I wanted to have was, it's been more than 1 year that we know and we have been treating COVID now. If a patient like this comes to you, other than antibody cocktail that we discussed, what are we doing early on? What kind of blood investigations are we doing as a general patient that we're talking about? What kind of therapy are we putting them on? Are we still doing the old school antibodies? The role of remdesivir in these kind of cases? If you could just briefly for 2-3 minutes give us a guidance of how, like what all we have learned in the last close to 15 months now, and what we are practicing now. Guru sir.
Yeah, so it's been a long 1 year, as you said, and various therapies have come and gone and have been thrown out of the window. But what has stood the test of time has been the good old dexamethasone, remdesivir plus minus. Some people say that remdesivir works. Some people say remdesivir doesn't work. But if you want to talk about my experience, I can talk about it, because even the guidelines which have come up actually, which recent guidelines which have come up in NEJM also, they talk about remdesivir as a effective antiviral, though it doesn't reduce the mortality, but it definitely reduces the time to hospital recovery and the amount of days on oxygen therapy. So the earlier we use remdesivir, it's always better, because it acts best when you are giving it in the viremic phase, as same as monoclonal antibody. I think, but in a patient who is already vaccinated, I would actually wait for a couple of days more, because the window period for me for remdesivir is actually a little more than for monoclonal antibody. And I can give remdesivir to a patient who's hospitalized and who is hypoxic along with my steroid therapy. So for a patient who is vaccinated, I would really wait. Initial tests you're talking about, Anoop, what we are asking, what I ask for in my patients is a complete CBP. There are a lot of data now on your NL ratio, which is a neutrophil lymphocyte ratio. So if this ratio is more than 3.5, generally patients are, we have observed that these patients tend to deteriorate. Mind you, this is N/L ratio is for patients who have not received steroids, because the moment you get steroids, it is lympholytic, so obviously a neutrophil count will go up. So in a patient without steroids, an initial presentation N/L ratio is one of the best markers to tell you whether, one of the really fair markers to tell you whether the patient is going to, go down in his clinical course. So asking for ferritin, LDH, C-reactive protein, they all probably add to the cost. And I've seen a lot of people having a COVID profile where they're doing a procalcitonin and a lot of other tests also. I think this one marker, I think I wish we could use more in our clinical practice, because we have now all the data collected of almost 100 plus patients with N/L ratio and correlating with their clinical progression, and has found to have literally correlated with their clinical course in the hospital. So I generally ask for a N/L ratio. And apart from that, if the patient is already crossing 5 days, a D-dimer to look at his thromboinflammation and put them on low molecular heparin if the D-dimers are elevated. Apart from that, I have rarely asked for C-reactive protein or ferritin or LDH in my clinical practice, especially in the outpatient department. I have relied more on N/L ratio. Our pathologist is there who tells me the ratio. And if it's more than 3.5, yes, I've seen that they have actually gone on for a hospital admission. So coming to the third part of the discussion was that Dr. Vishwakranth was talking about bevacizumab, which is Avastin. It is used generally for diabetic retinopathy. It is an angiogenesis. It's an anti-VEGF antibody actually. We have a study which is now just accepted and about to be published now on bevacizumab. We used in around 15 patients bevacizumab, and our this thing data is pretty encouraging. What we could get out of bevacizumab as compared to tocilizumab, this actually doesn't increase the chance of infections. It is anti-angiogenesis, so it reduces the pulmonary edema in a patient, the vascular leakage in the lungs. So it's a very attractive proposition for people. The only deterrent is the cost. The original molecule Avastin costs around approximately 1.1 lakhs. The lesser one from Cipla costs around 59,000 rupees. But if you compare it vis-a-vis a patient going onto a ventilator and once what I've observed, Anoop, is that the moment a patient goes onto a ventilator in COVID, it is going to be a long haul. So it's like it is really a very long haul. It is unlike a patient with swine flu or other cause of ARDS, where we know within 72 hours the patient is going to come out or not. Either the patient recovers or the patient doesn't recover. It's as simple as that. But in COVID, the patient just keeps on prolonging. They go into ECMO plus minus ECMO, and I'm sure all the intensivists who are there must have experienced this. That's why we have a problem with beds in COVID, because once the patient goes into the ICU, it's like 2-3 weeks in the ICU with the ventilator on. So now again, I would tell all the people who are there in this forum is that if possible, please use antiviral therapy as soon as possible. Monoclonal antibody, if cost is not an issue, probably use that if cost is not an issue. And use of remdesivir. I've been a proponent of remdesivir, that it works. It definitely works if used early on in the disease.
Perfect. Thank you so much, sir. Karthik sir, for 2 minutes, if you could quickly suggest me what you are doing in your contemporary practice for not so sick COVID patient in the current era. Karthik sir.
I think Karthik might be.
Yeah, Deepak sir, if you could share your experience real quick.
Yes, I think I perfectly agree with Guru Prasad sir. So for me, everything is I'm like about the timing in COVID. So you need to anticipate the high risk patients. You need to start whatever the antivirals you have at hand earlier. And if once your time is over, I think nothing works. Right? Once your inflammation has started, only the steroids and toci is there. Apart from it, nothing major will work. And once the patient goes on to an advanced oxygen support or maybe a NIV or more than that, I think nothing. I'm like, it's going to consume your time, energy, and personal. That's it. And about the antibody cocktail and all, one thing I would like to say is the recovery trial, basically, which has showed the benefit. There's a line that I think when you don't do an antibody on a larger scale for everyone was included, there's not much of a difference of the outcomes. So you need to select your patients very clearly. At least at our place, we don't give to the patients who have an antibody, at least the anti-spike protein antibodies. Second thing is, more important thing is, there may be a possibility of emergence of resistance as more and more variants come. So you need to salvage this therapy and keep it in your armamentarium. One good thing is, I think there was a proof that it works for all the variants which are there now. So that is one good thing. So it should be a judicious use. Remdesivir, as sir has told, I think I was also one of the persons who supported usage of the remdesivir, but again it depends on the stage of the disease. Most of the trials which were done earlier were done in the later part of the disease. But I think 2 days back the veteran affairs trial came and it was showing that till now we know that remdesivir may work or may not work. It may work in some places, but now this trial has showed that it may actually increase the duration of hospitalization. So now it I think it will be kind of the cupboard of convalescent plasma. But I'm not really sure about that. For us, the toci actually worked it. At our place, I think toci for us, it depends on the timing. If you really decide your patient who is actually going into the storm, for us, toci has given a very good result. Bevacizumab at our place, I think we have used it for some patients, but incidence of DAC has prevented us from using for more and more patients. Steroids, one thing I could say is, once you go above 1 mg per kg or 2 mg per kg, not more than that, and at least in our practice, we found that there's not much of a use. And for us, most of the cases now are with the mucor. So we are fed up. Everyone is asking about how much dose of steroid are you actually giving to the patient, or even the patient's attendants are asking. So that's it.
Perfect. Thank you so much, Deepak sir. May I ask Somaraju sir to give his comments on today's topic and the discussion that we had, and if he has anything to add? Somaraju sir.
Good evening to you all. Thank you, Anoop. I must congratulate Vishwakranth for coming out openly, and also congratulations for the wonderful recovery, Vishwakranth. And having said that, I don't have to tell you, while I am not a specialist in this area, I have a general interest in medicine overall. Having said that, one thing simple I can say is the monoclonal antibodies, from the experience of many of you mentioned, and Vishwakranth's experience, and our colleagues at the place I am practicing, they have a very positive thing to say, and most of the patients are helped. But again, having said that, it is repeatedly emphasized it helps in the initial phase of the illness. But it is also, people go out of the way to say it harms the late phase of the disease. But be aware, whether it is the initial phase of the disease or middle stage of the disease or late stage of any disease, no disease is a singular entity. Just like a myocardial infarction is not a single disease, even late phase of COVID is not a single disease. And absence of proof that it doesn't help is not proof enough. Absence of proof is not proof of absence. Be aware of studying and following up on patients where the answers are not simple. And then I have a feeling we have a tendency to just take shelter under some publications most recent. Don't get into it. And then what helps in the initial phase may not harm some of the patients, may help some patients, may harm some patients. It's like saying, late phase of sepsis and septic shock, antibiotics won't help. And somebody tells you that antibiotics also harm, you want to believe it. So don't oversimplify it. Went through this in other phases of illness. This type of illness we never saw in medicine, and we are very ignorant about it, and only some aspects we know now. Thank you.
Thank you so much, sir. And I think it is very relevant. My biggest concern whenever I'm dealing with COVID discussion and COVID treatment protocols and the available therapy and what we have seen in the last 1.5 years, my biggest concern is that we are all desperate. We as a patients are desperate. We as a clinicians are desperate. We are looking for a quick, simple, easy solution, which unfortunately we are not finding. So what ends up happening is anything which gives us a ray of hope, we use it to the point of misusing it. And that is literally what happened with, call it remdesivir, call it dexamethasone. I have had patients who are being given 1 gram of solumedrol daily for God knows how long. And these are happening in established hospitals. And I don't know, maybe there is a theory behind giving 1000 milligrams of solumedrol. I don't know. Solumedrol is methylprednisone, so I don't know. But the idea here is that the fear comes of, are our actions making the drugs not work rather than the drug itself, be it plasma, be it remdesivir, be it steroids, and now in this case, monoclonal antibodies. And the second fear comes is that when we do think that any of these therapy are helpful, then the whole race comes around whether we can give this therapy to every single person, and no matter what is the situation, it's too difficult for us to figure out how to select a patient, just randomly give it to every person. What ends up happening is what was happening a few months ago, where nowhere in India remdesivir could be found, nowhere in India tocilizumab could be found, and for various human behaviors, be it on the patient side, be it on the doctor side, be it on the authority side. So my fear is just rampant use of a drug at places where it does not belong, and B, when something like this happens, drug doesn't become available to begin with. And we have seen that multiple times. It doesn't seem like we are learning from what is happening. And by we, I don't necessarily mean doctors as a general, but as a community, we keep making same error every single time. So here's my one last question, and then if anybody has got any other thoughts, we'll take up, otherwise we'll close. Here is one last question that I have to all the attendees here. How easily is monoclonal antibody available right now? Does anybody know? Vishwakranth sir or any of our experts? Is it difficult right now? Can we get it immediately? What is the situation? Is any Indian company making it? Anyone? Vishwakranth sir?
For me, I mean, I should say I was lucky it was there. I just walked into DEC. I mean, there was no, but when asked for the doctor whom I suggested or my source or someone, it took 24 hours for them to get to the hospital. I mean, maybe if it will take a day, that's the present scenario. I think so with better logistics. I think so present load it is available. We can't say the same maybe a month later, but presently I think there is not a big list of waiting list people who would want to take and it's not available. That scenario is not there yet.
Guru sir, you think we are going to misuse the antibody therapy, and what is the availability scenario, if you can give us some idea?
So, Anoop, you made a very interesting observation that we keep on making the same errors again and again, you know. So I can see that happening now. It's not at the level of healthcare professionals, but it's at the level of the community. Again, people are behaving as if, it's like 1.5 months back that people are posting WhatsApp videos saying that, please give a bed to my father, to my brother. We were getting desperate calls in midnight saying that there is no oxygen bed available. And now people are outside without mask, eating chaat, eating pani puris, nothing has happened. So your point that we keep making that same mistake again and again is very much valid, and I wish that we could start from the grassroots about having appropriate COVID behavior. Number one. Second is, yeah, availability in a population-rich country like India is always going to be an issue. Be it something like as basic as oxygen, where people were left. I think the scenes were still have not left my mind, where people were outside in the ambulance in Delhi struggling for oxygen, and people died in the hospital because the oxygen got finished off and got emptied. So it is going to be a challenge. So when we're talking about monoclonal antibody, we're talking about an extremely expensive drug. So its shortage is also going to be there. Hoarding is going to be there. Black marketing is going to be there. We have seen all this, and it's going to start from the kind of behavior which we are following right now, where we are in denial again and thinking that COVID is not there anymore. That is very unfortunate, but I think we are waiting for the next disaster to happen again.
And sir, this truly is my biggest concern, because if we do have a drug that works, first of all, that there is too many ifs. If we do have a drug that works early on, it certainly seems like there is some positive signal out of it. Of course, it's a costly drug, and anything regarding COVID is new. We don't have 10-year data with us.
See,
But
I'll tell the logistics to you. See, we were using remdesivir for hospitalized patients, okay, which was only 15% of the people who were infected, right? So we had a shortage of remdesivir. Can you believe that? To cater to 15% of infected people, we had a shortage. Now the guidelines for monoclonal antibody, you just see it is for any patient who is infected within the first 5 days. So we don't have time to assess the patient who is going to get hospitalized. It is for an outpatient. So any patient who has COVID should, by technicality, get this monoclonal antibody. If you strictly follow guidelines, then a BMI of more than 35 or age of more than 65, 55 with hypertension or any other comorbids, or a patient having asthma, or a patient having diabetes. Now, every third person in Hyderabad is a diabetic. Okay, so just see the burden of disease now if we get a third wave, and how many people will be, kind of eligible to get monoclonal antibody. And then you do the maths and then figure out that, why we will not have a shortage.
absolutely, sir. Your point is absolutely well taken, and I think this is one concern. So, as a healthcare professional, we certainly need to continue to educate people, not just in terms of disease, but also in terms of their behavior, so that A, we try not to get into the kind of disaster that we had a couple of months ago, and B, also to try and see how we can ration this drug in a better way, so that at least people who are at the highest risk strata, they get this drug. We are 7 minutes out of our scheduled time. If anybody has got any final comments, otherwise we'll go for the closing comments from Dr. Praneeth. 1 more minute if anybody has got any final comments. Okay, if not, then Praneeth, your closing comments for today's session.
Yeah, one of a kind discussion where we had so-called bedside clinical case discussion, getting the patient himself and asking the questions and doing a kind of an interrogation. So very interesting. Thank you again, Vishwakranth sir, for accommodating. It's been a pleasure listening to you, and thank you, Guru, Deepak, and Karthik, for your thought process. I think definitely a lot of questions answered about antibody cocktail, when to use, how to use, and where to get. And I hope the COVID crisis will not bother us more, and I hope the one who deserves this cocktail and get benefited should deserve this, and he should not be in a position where he's not able to get these things. And I hope this drug does make patients as well as what Dr. Vishwakranth was got the benefit. So I think excellent discussion. and I believe many more discussions should happen like this. Thank you one and all for making this discussion fruitful.
Thanks, Praneeth, and thank you all of you for attending. Special thanks to Vishwakranth sir. I think this has been a repeated theme.
So many times, man. After all, I am your colleague. No need. Thank you very much. It was a joy for me too.
And for attendees who joined today but who has not been a part of our WhatsApp group, I have put in the link in the chat box. What we tend to do is once the session is done, for any comments, for any discussion that we want to continue from here on, we do it on the WhatsApp group. So if you are not a part of it, please click a link on the link, and you will be joined to the group where we discuss mostly the fallout of what we have left from that Wednesday's discussion and the upcoming sessions as well. And as most of you know, all the huddle sessions, they're recorded and we upload it on YouTube and podcast. You can simply just go and search for the weekly huddle and you will get the previous recording so that you can listen to it in your leisure time, when you're driving, when you're at the gym, when you're walking, something rather than just plain old music or something like that. So with that, I would like to close, and again, thank you all for attending. We do this every Wednesday at 7 o'clock, and we will see you next Wednesday with a new topic. Thank you all. Good night.